So the current prevalence, if you take it in Sri Lanka, so we have reduced to less than 1%, but there are pockets of transmission still existing. Things are there. So based on your recent fieldworks and researches, could you describe the current prevalence of major helminthic infections in Sri Lanka and how your interventions have contributed to maintaining further reductions in the transmission in high risk areas?
Okay, so again, there are two caveats that I need to introduce here. One is I've not really been actually doing active research for now a good 7-8 years because I've been in
academic commitments.
Yes. And also, I must also say this, what I've done is document prevalence, document the decline in infection, the actual intervention and the control measure, the implementation has been done by the Ministry of Health. Right? Our health personnel who are out there, who are working at field level, they are the ones who made sure that things are working. Right?
Yes.
But getting back to the issue of the at-risk populations, the vulnerable populations, so what we've seen is for soil transmitted helminth infections, where the connection is really fecal contamination of soil, the two populations that still are at high risk really are the low-income urban settlements and the plantation sector communities. Both of those because of the inadequate access and use of latrines. So the environmental contamination continues, and also in roundworm and wickworm infection, those eggs that are produced by the female worms, when they contaminate the environment, if they are not in direct sunlight, they can survive for years in soil. If there is a little bit of moisture and shade, they will survive for years. Hookworm is a little bit more vulnerable because the egg hatchers and the larva is not protected by that eggshell. And so extreme cold, for example, we don't see hookworm in Morelia district because overnight the temperature drops and so their larvae are killed off. But at the lower level, lower altitude things, they will survive. Roundworm is the egg that is really very hardy. So those contaminated environment continue to give that what we call backyard transmission. There are children, young children, preschool children, primary school children crawling about on the ground. They go and play outside in the soil, and then they don't wash their hands. Their hands go in the mouth, or whatever is dropped on the ground is contaminated with those eggs. So that sort of continues the transmission even long after fecal contamination has stopped.
Definitely, I think we are saying that two communities, plantation community and urban slums, are still again the same problem. The poor sanitation, the latrine facilities, and also the education-wise marginalized communities are the reasons for these two groups. Okay, I want to get your experience about these deworming programs we had in the country. I think we had implemented school-based deworming since 1960s onwards. Lot of programs we had. So could you share insights from your involvement or your experience or your research works done on this deworming program? What operational challenges or your lessons learned through these deworming programs, madam?
Okay, so I think in Sri Lanka, because they started off with mass deworming of entire populations and then switched at some time in the 50s, that's not been documented that well how that strategy or policy transition took place. But nevertheless, I know that from the 50s, school medical inspections and deworming has been part of that school health strategy.
Still continuing it.
Still continues. So, but that kind of, so what the health ministry started kind of gave a message to our people that every child should be dewormed on a regular basis. So a good parent will make sure that maybe like every school holidays as a routine, their child is given some deworm.
Yeah.
So whether it's given through the school or not, given that now the anthelmintic prices have come down, a lot of parents will go to a pharmacy and get anthelmintics for their child. Whenever we have done health camps, one of the things that happens routinely is that the children are sent, mother said to ask for deworming tablets. Right?
Making it available publicly and simply, and also public health workers are available with any time with PHAs and midwives with deworm tablets, another key success.
So it kind of has, and because they are so safe to use, virtually no side effects.
Sure.
Right? The only time I remember this is, I don't think we had any cases in Sri Lanka, but I do know that internationally when they were doing routine deworming programs, and they were recommending deworming of preschool kids, there have been occasions where the child aspirates a tablet. The child is crying for whatever reason, don't like to take medicine, and opens the mouth, and the whoever mother sometimes puts the tablet in the mouth, and then child is crying, bawling at full strength, the tablet goes the wrong way.
Okay.
So those are the really, apart from that kind of very, very rare incident, anthelmintics are
earlier is a bitter taste. Nowadays we don't have it. Maybe.
So what is it? Kinopodium, TCE. There was anthelmintic that used to be used, that used against hookworm infections, which used to irritate the roundworms. And then, because multiple infections are also combined infections are common. Used to be common. Then the roundworms start, because they're irritated, they migrate, you find the worms are coming out through the nose, and it's really horrid circumstances like that. So they used to then, those days, recommend first you deworm for the roundworm, then only you give the anthelmintic for hookworm. But now, albendazole, they just work on all of those pieces, that broad spectrum, so you don't have to have that kind of concern.
Yeah. So okay. So that's again thing. You mentioned about how this wash integration is important for this. Wash means water sanitation is very important for this worm infestation control and things. So that's the main problem we have now. In the marginalized communities, again the wash issues are the key things to things. Yeah, again the persistent hotspots. Still we have the hotspots for that.
So in addition to wash for hookworm, you know that the larvae enter the body through the skin, unlike with roundworm infections and whipworm infections where you actually ingest the eggs. With hookworm and also spondyloidiasis, which is underestimated, the larvae enter by piercing the skin. So when you are walking on contaminated soil, if you are going barefoot, especially between the soft skin, between the toes, etc., that's where the larvae enter. So use of footwear is also something that is of value. Especially against hookworm.
Yeah, that also is the economy improvement. I think people are educated and things.
Again, there is an attitudinal issue there. There used to be. I have heard reports like the women who are at the bottom of the rung are told by the supervisors they can't wear slippers.
Yes.
Right? And so that
like a caste system, things.
So I don't think
that also, madam. Another thing, so still nowadays I am dealing with this leptospirosis. When we are interviewing the farmers, when they are going for paddy field, they don't wear the slippers. So
yes.
Maybe
so then the risk of getting that whatever the leptospira entering through abrasion increase. So those are the attitude
changes we need things. One more thing. Still we are struggling for this pinworm investigations, madam.
Yes.
So any advice you can give for these public health professionals on how we can?
So from the more recent surveys that we have done and studies, so pinworm, so the soil roundworm, wickerworm, hookworm, we use stool samples and examine that in the lab to diagnose whether the person is infected or not. Now, pinworm is a different, okay, it's an intestinal helminth, but the mode of transmission is different. The adult female worm, when it's gravid, comes out of the anus and the eggs are then deposited on the perianal skin. So it's sometimes in the feces because it contaminates the feces that's coming out, but otherwise it's really on the perianal skin. And the movement of the female worm causes itching. The eggs get stuck onto, they are very sticky. They get stuck on fingers because of the perianal itching, and then from there they get transferred onto objects that are used in and around the household. So it can be plates, furniture, it can be clothing, bed sheets, linen, all of that can get contaminated within the household or even within a school environment. And so it spreads, you don't need soil contamination there. It spreads really easily, and it's still persistent even in temperate countries like in the European countries because of that mode of transmission. So how do you then get rid of the infection? Deworming, it's very sensitive to albendazole and mebendazole. So even a single tablet will kill it, but then the thing is that you get reinfected. So if the contamination is really widespread. So then you need to make sure that they repeat the treatment in 2 weeks, clean the environment, swab it down with some kind of antiseptic, boil the clothing, underwear, put it out into the hot sun to dry. There are other supplementary measures that need to be taken.
Okay. I think these helminthic infections and things are success is a team approach. It's not only the public health team. So how this team approach, this person public health, these helminthic infestations will overcome even the persistent helminthic infections, you think? So
at a national level, I have worked closely with the Family Health Bureau, so that their determination of what the strategy that should be used in terms of deworming was informed by the work that we did with relation to determining the prevalence and what were the high risk areas and so on. And so at that level, at a high level, collaboration between parasitologists and public health community physicians worked at that level. But I think even at a field level, in a MOH area, the public health midwife giving the awareness to families, the school medical inspections where our public health inspectors work with the school team, and so on. So you have to bring in a lot of people to support each other in getting this message.
Parents, including teachers, to be educated, and they also have to regularly educate the children.
So during the surveys that we did in the various schools, I always made sure that the teachers were involved in this, and the teachers knew what we were doing, the risks that were being run, and then at the end of the survey, when we give anti-helminthics to the children who participated in the survey, we did that with the cooperation of the teachers. So the teachers also.
So based on your experience, so you are controlling this helminthic infestations.
Sorry, there's something else that I forgot to share about the risk of one incident that happened, which stayed in my mind. Teachers giving anti-helminthics, the water that they used to give. So one particular school, it was in a tea plantation. They had sprayed insecticide and the water source that was used to give the children the antibiotic during that school medical inspection, for some reason it got contaminated with that pesticides. So then the children were vomiting. They were vomiting not because of that
anti-Helminth 6,
but because the water was contaminated.
But
so
people will blame this anti-Helminth is a reason for Ministry of Health.
To be
careful on that aspect.
Things
sure. This is a thing we have to to make sure nowadays. Resistance against for these medications.
Because small incidents like that go viral, and then everybody thinks that this is that tried to kill our children kind of story goes around.
How do you overcome this? There are some other taboos, like if you are taking anti-Helminth, you have to not eat these oily foods, and you should not eat fruits and other things are there now.
Actually, you can take antibiotics even on an empty stomach or after eating. It doesn't matter, because the thing is that the mebendazole and albendazole act in the gut fluid. They don't need to get absorbed. Right? That's why their side effects are also so minimal, because they don't get absorbed. They act in the gut lumen.
Yeah, that message to be passed. Still, the parents are having still the worries about giving deworming. Eating things. Okay, but based on your experience, these strategies for our current communicable disease, how we can use these strategies? I didn't put the question.
I think one of the big lessons to learn is that you have to not only think about the positive side of what you're doing, but also think about what are the negative, unexpected negative consequences. So, okay, we were not going to talk about lymphatic filariasis today, but I do know that when we were doing mass deworming programs on lymphatic filariasis, but over repeated years, the cooperation in some communities with the deworming was very difficult, because there was this myth that it was going to cause subfertility. So you have to be very alert to that kind of misinformation and the myths that people sometimes unknowingly perpetrate. And so have your ammunition ready by telling people this is not so.
People among themselves, they are spreading it. We don't know. So that's what these qualitative researches and these key informants, they will come up with this kind of.
They used to say they are giving these drugs for free because it's close to the expiry date.
Expiry date, yes.
Then something else that was not from Sri Lanka, but I remember this being reported from Bangladesh, was that the tablets come in bottles, and they are not individually in blister packs. Again, that if having it in blister packs made it more kind of attractive for that they were safe, and that kind of approach was there. So sometimes you have to think about that kind of extraneous matter.
So is it relevant to this Helminth infestation with the climate change? Is another things we can get it again? Is there any possibility?
Okay, I don't think that climate change per se is going to affect us that much, but what could happen is that with the economic consequences of climate change, if poverty increases, then there is a risk.
So gap is wider between rich and poor things. So there are certain, not only estate or these urban slums, there are rural villages also.
So rural villages. So that's interesting that you mentioned that, because my colleague from Rajarati University, Kosala Veerapan, and his team have been working in and around Anuradhapura district, and they have found in those schools in Anuradhapura that there are a lot of strongyloidiasis infections.
Recently?
recently, in the last 2 years,
Okay.
right? In some schools going up to 10-13%. Now, strongyloid dialysis is something that we have seen only very sporadically in the rest of the country. So I don't know what exactly is going on there. But it could be that those are all rural communities. Fairly remote schools. So it could be that those communities, he's looking into this in more depth. Sanitation is poor, and so then infection is continuing.
So these are challenges for future. I think so, because this. I don't think it will cross border. It will enter. I think, but this is the way.
Unlikely. But, those are the so climate change per se. As I said, no. But if it, if farming communities are driven into poverty because their agricultural activities are at risk, because repeated cycles of flooding or drought, and their income sources are you can have, it's not, you can imagine that you can have people being driven to poverty because of that impact, and then because of the poverty and the lack of the infrastructure, the sanitation infrastructure.
Maybe another thing, maybe drought, maybe a lack of water in future, maybe another thing could be a things for our things.
I share one other story with you, which I think you might want to include or not, but this is again going back to my very early days of working as a parasitologist. I would like to recall the contribution made by Professor Maruf Ismail. Right? Professor Ismail was a professor of parasitology in the Colombo Medical Faculty when I was a student there. I was a postgraduate student as well. When I passed my MD exam, I went to speak to Professor Ismail and to thank him and say that I have got through the exam. And I asked him, sir, is there anything that you have any ideas for good research going into the future? He was on the WHO expert committee for parasitic infection. I said, Nilanthi, there is a practice that is happening in Sri Lanka at the moment where we are giving antenatal deworming to our pregnant mothers. It's not being done anywhere else in the world, but I think it's really good. It's safe. If you can show that this is effective and safe with the scientific evidence, that will be a big contribution. So, with Professor Ismail's support and advice, and with other colleagues from obstetrics and gynecology, I just moved to Ragama at that time. We put together a study where we followed up mothers who had been given anthelmintics or not during their period of antenatal period, and then we looked at their babies. Weighed their babies, looked at it for teratogenic effects and so on, and we found that it was safe. The mothers who had taken the deworming, so you know very well that it was introduced because of the risk of maternal anemia
and postpartum hemorrhage,
hookworm infection as well. So the deworming was to counteract the hookworm and reduce the risk of maternal anemia. Right? So what we found was that it was safe, and the baby's birth weight was bigger. It was actually beneficial. We didn't have that much hookworm by that time, but nevertheless we were able to show that it was safe. And so that finding from Sri Lanka, actually we reported back to the WHO, and WHO then so the paper was published in the Lancet, and this I'm talking about before all of these online things became available. WHO used that as a foundation to base their recommendation
to other countries.
So things that we do in Sri Lanka can really be an example for the rest of the world.
Countries. So who initiated this anti-worming treatment during pregnancy? Then is a pioneer in.
I think it would have been the obstetricians, right? Because they knew that there was a lot of maternal anemia, and so what were the risk factors for anemia? We also knew that hookworm causes anemia. It was a well-known thing, and in adult population still hookworm is a problem. So I think it would have been the obstetrician.
Traditions.
It's not that initial part is not really documented properly anywhere. But we do know that in 1994, the Family Health Bureau issued a Health Ministry circular saying routine anthelmintic use in the second trimester of pregnancy.
Based on your work, I think.
No, that actually had happened before.
Before that, okay.
I came in much later on the scene to
document it.
There was no safety data at that time.
Okay,
right?
no safety.
I provided the safety
data.
The safety issue, the safety
on mother and on the child.
From experience.
Yeah. Okay.
So, yeah.
Okay, thank you.
I wanted to specifically tell you because that was something I think that was very special to Sri Lanka and something that we were able to do for the rest of the world as well.
Yeah, thank you so much, madam. I think this interview make you also recall your past experience and to your past days.
Yes.
And you spend with us the time, and definitely it will be support our public health and our future public health team. Definitely, I think they will learn through this. This is a thing we want to document these things. We can't write and
very much so.
Okay. Thank you so much.
Thank you.
Right.